Hello everyone. Good morning, good afternoon, good evening, wherever you're watching from right now, and welcome to JhermiNATION PBR Hub for Health, Arts, and Business. And I'm your host here, Jeremy, in London. And I take it that you're all doing well and keeping safe wherever you're watching from right now. So please write in the comment box where you're watching from. And I would like to welcome Juliet Olino de Mayakyat. Hello there, Cherry Kucherus, Cathy Valdez, and Julie Simmons. Welcome, welcome, welcome. And yes, please write in the comment box where you're watching from. Any questions, comments, or suggestions later on. This is a very important topic that we have right now for today in this episode. So please, stay with us. And just before we continue, I would like to invite everyone to for a minute of silence. Let us all remember all those who were infected, who died of COVID-19, and all those who lost their job because of COVID-19.
In our darkest moments, they have pulled us through. As they rest, it is now up to me and you to never let their memory fade away. In our hearts they'll stay, may they guide our way as we face a brighter day. They gave their lives so we can carry on. We owe it to them to work harder, show compassion to each other. And as the storm subsides and we can see the rain.
Yes. So, our very special guest for today is today we're going to concentrate on the health side of JhermiNATION, our hub for health, arts, and business. And I thought of this topic because this is very common but very preventable as well. I was a clinical nurse specialist for stroke for 3 years in Queen's Hospital in Romford, Essex. And I have worked with our very special guest for today, who used to be our lead stroke consultant in Queen's Hospital in Romford, Essex. But at the moment, he is the divisional clinical director in King's College Hospital. He's also the deputy medical director for NHS England and Ireland and Improvement. He is also the improvement director of NHS England and Ireland for interim or IMAS, so what we call interim management and support, where he authorizes NICE guidelines for stroke. So NICE actually stands for National Institute for Health and Care Excellence. He's also a committee member of for Clinical Reference Group for Neurosciences in the UK. Also a professor of stroke medicine, a senior clinical lecturer for South Wales University, and he's a chairman of Reconfiguration Panel for Stroke in South Essex, chairman of Diagnostic Recovery Board for Midlands in the Physiological Sciences. So without further ado, let's all welcome our stroke consultant, Dr. Sreeman Andole. Hello, Dr. Sree. How are you?
Not bad at all. I mean, say, I thought that you were going to talk about stroke as well. You've taken a long time to introduce me.
I have to edify you. yeah.
All you need to say is that, I'm a very hardworking doctor.
You are.
And
Absolutely.
I've worked with stroke patients as long as I can remember, since the stroke is the specialty. So there you go. That's my experience.
Amazing. So please greet our viewers here in JhermiNATION, Dr. Sree. Thank you as well for for accepting my invite here to be here today.
Well, I'm glad that you invited me, and I'm very honored that I've come to your platform, and I can see that there's loads of how to say, you got the right platform. I like to wish you good luck and success in all your future ventures, whatever you plan to do.
Okay, thank you. But Dr. Andole, this you are in JhermiNATION, and I always do this
No,
to my.
fair enough. Fair enough. Go for it.
I always do this to my special guests, and nobody escapes my quick fire questions.
Oh
Are you
my
ready
God.
for this?
Whatever
This is
that is, you're not going to burn me up.
yeah, no, no. This is a very serious topic that we're going to to educate people about this one. But first, we need to have a little bit of fun, and we want to know you more. I know you, because I've worked with you for 3 years, and of course, to relax you a little bit. I know you've been through a lot of like interviews as well, but nobody escapes my quick fire questions. Are you
No,
ready for this, Dr. Andole?
I'm too nervous. Too nervous to face you, Jeremy. No, this is a tough one for me. Go on. I'm really
Okay.
nervous, but you need to make it feel easy for me. Yes, thank you.
Yes, sleep or eat.
Please, yes, indeed.
Sleep or eat.
Oh well, eat.
Eat. What was the last thing that you Googled?
JhermiNATION.
Oh, thank you. What is your guilty pleasure?
Um, Guilty pleasure is listening to music.
Wow, amazing. Do you focus more on your strength or focus on your weakness?
On my weakness.
Okay. So do you do what you wanted to do or you do what you are obligated to do?
Do I what I wanted to do all my life?
Amazing. Amazing, yeah. Tea or coffee?
Always coffee.
Coffee. Happiness or fulfillment?
Happiness.
What was the lie that you recently told?
And the lie I said is that I'm prepared for the future.
All right. Money or fame?
Well, you know what? I don't want neither.
Okay.
Don't want any of those.
Fair enough. And what would you tell your 12-year-old self? If you're in front of Sreeman Andole, in front of you right now, what would you tell your 12-year-old self?
I'll say that enjoy your life.
Amazing. Very simple but powerful and very true. Thank you. I hope you enjoyed that one, Dr. Andole.
That's all right. Absolutely. Same here. Looking forward.
Okay. So let's just let me just share my slides actually, so we can get people into the perspective of what we're going to discuss today. Just bear with me. It's not. Oh, it's not. I think it's my internet connection. Oop. How are you today, Dr. Andole?
Do you know
You
what?
had your lunch?
I can tell you a good story if you want me to.
Yeah, sure. Why not?
Fill the space, and I tell you what, I think it's not so good week for me. One of my dear friend, one of the medical directors who I work with at King's College Hospital, he suddenly had a heart attack and died. He was only 56
Oh,
or
okay.
57, and he was driving to work, and he died. And that brings not just the life into perspective. I know we always hear of people. I come to work every day and I meet with people who are dead or dying. But to see one of your close and near ones go like that in a second is something hit me very hard. And he worked tirelessly throughout the COVID, just like you and me, coming to work every day, trying to meet and make the ends meet and try and see what we can do. But unfortunately, you know what, we don't know what is around the corner. And he was reasonably fit and young man, doing things all right. He was enjoying, have a lovely family and enjoying his life. And one minute he was there and another minute he's not. So, and I kind of, when you actually said that, shall we just kind of have a minute silence to remember the people who have lost with COVID, and I have my special minute for him as well. So, it's not been a great week for me. So that's where I would start. So I think it's important that we we realize that the people who are closest to us are how important the family and friends are in our life, not just the work.
There you go. Uh, I've lost the transmit the I've lost connection there for a few seconds, but we are back. So, yeah, our topic for today is actually about stroke. So, first of all, I would just like to there's this is a very common thing that I have encountered when I was a stroke nurse specialist at Queen's Hospital. For people, they're confused between stroke and heart attack. Yeah, so let's just clarify that one first. So obviously, heart attack is in the heart to start with, and stroke is actually in the brain. Yeah,
Right.
it's almost the same mechanism wherein there's a lack of blood supply due to a blockage in the blood vessel, and then obviously there's an interruption in the function. But yeah, so that's the difference. So stroke is not the same as heart attack. So that's just to start with for all our listeners at the moment who are not medically trained. They have no background with the health profession. So stroke and heart attack, they are different. Yeah, stroke is on the brain, or some people are actually say it. When I was working in the Philippines, actually our term for stroke is brain attack. So it's the same with heart attack, but different organ, same mechanism, but both of them are emergency anyway. So yeah, so stroke is just a layman's term, but the medical term for that one is cerebrovascular accident, yeah, or CVA. So Dr. Andol, please tell us the incidence of stroke here in the UK and worldwide as well. As far as I know, here in UK, every 5 minutes there is one person who is having a stroke. So every 5 minutes there's one. So please tell us the incidents, such as you know the gender that it affects, ethnic group, age. Is there any particular age group, or all these things? So we have an overview how serious a stroke is.
Right.
Please,
Okay.
Doctor.
Now, the first thing is thank you for kind of bringing back to where we need to talk about. I think you're absolutely right. If you were to talk about a heart attack to a teenager or even for a school children, they would know what exactly heart attack is because somebody holds their chest tight and then somebody complains of a pain in their heart. They would call an ambulance and then they would ask them to go to a hospital because they know that it is serious and important. Unfortunately, people are not so aware of what stroke is because the
Mm,
first and the most important thing is 10, 15 years ago there was no treatment for stroke. Stroke was stroke and the people, there wasn't anything more to do about it. But
mm,
10, 15, since last 10, 15 years ago, since last 10 years, the treatment for stroke has improved remarkably, and we can almost reverse what has caused the damage to the brain. Almost there, quite, and not completely reversed, but we are almost there as close as we can get. So I think things have changed. So it's important that the people need to go to the hospital as such. I think that is the first bit.
mm,
So you're absolutely right. You talked about incidence of strokes. Incidence of strokes, 1 in 5 minutes. Every 5 minutes, stroke strikes in UK. There are millions of people. There are about, I think, more than 40 million people in the world who are affected with stroke, different types of strokes and TIA at any given point of time. Within London itself, there are about 13,000 strokes
mm.
every year.
Wow.
So, and we got about 8 HASU centers in London, so of which each stroke unit, our HASU unit, sees about 1,000 odd strokes. Yeah. Plus, you add the TIA, which we'll come to it later, which is a mini stroke. We have another 500 of them. So 1,500 people coming to the hospital from every part of London with some degree of damage to the brain. So it is quite a significant impact to the kind of population. To bring things into perspective again, stroke is the single most. If you actually add stroke as well as cardiovascular disease into one, it is the single most cause of death and disability compared to any other cause in the world. It trumps even cancer and road traffic accidents and everything else. So I think it kills, and it's still 1 in 8 people die of stroke once they have it within 8 days. So it is still a big killer. It is important that we not only need to prevent stroke, but also try and get the patients have the right treatment when they have one stroke, when they have it. It's very important.
Is it, doctor? Is it common? Is there any specific ethnic group or that
Right.
affects a stroke?
Okay. Yeah. Well, I mean, say that's a, it's a good question, because I say it's a good question because it's difficult to answer. So the first question is, yes, there are certain ethnic groups which are more in which stroke is more prevalent, such as
Mhm,
South Asian. I come from
mhm,
India, so yes,
mhm,
South Asian groups, and including Philippines,
mhm.
Filipinos have a very high incidence, are twice uh, more likely than native population in UK to have stroke. So they're quite, it's quite common in them. Not just that, African and Caribbean population, they also have higher incidence of stroke than compared to the native white population. So there are so there are certain ethnic and racial groups which are likely to have incidence of stroke higher. Now, the reason why I say it's difficult to answer is because it is very difficult to say whether that is because of race and ethnic characters, or is it because of the underlying conditions they have. So, but we also know that the patients who are, or rather people from South Asian, are more likely to have diabetes, and they are
Mm.
more likely to smoke, and more likely to have obesity, and so those things are more prevalent in those populations. So it may well be that the race is important, but actually the other risk factors that kind of overlap them is probably more significant than the race in itself.
Yes, amazing. Thanks for enlightening that that question as well. Is it common to male, female, or is there any
Right.
particular
Okay.
age group?
Well, I mean, again, is generally speaking, you're absolutely
Mhm,
right. Generally speaking, males are more prone to have a stroke compared to females. But as the age tends to beyond 75, they're probably more. There's no really gender gap. They probably are more or
mhm.
less equal. So
Yeah.
it depends also on the type of the stroke. And of course, younger the population, you see different types of stroke. The older population will have slightly different types of stroke. That will come to later when we discuss about the types of stroke, I suppose.
Yeah, thank you for that, Dr. Andole. So, what will be the causes? Obviously, people will be asking, what causes a stroke, or what are the predisposing factors? As far as I know, there are like modifiable risk factors, and there are non-modifiable risk factors.
Yeah. So let's actually talk about stroke in three forms, shall we?
Mm.
So
Yep.
85% of strokes are caused because of blockage of blood supply to the brain, which you have
Mhm,
already alluded to at the right at the
mhm,
start of the talk.
mhm,
And those are called ischemic strokes.
mhm,
15% of strokes are caused because of rupture of blood vessel around the
mhm,
brain, and that causes the death of brain cells as well. So that would be about 15% of strokes. And the
mhm,
rest are called the TIAs, the transient ischemic attacks, which is a temporary loss of blood supply to the brain. Now, the cause of, so depending on what type of stroke you have, the causes are different. So
mhm,
the reason why you have a blockage, or a blockage to the blood vessel supplying the brain, is either because of atherosclerosis, which means that
mhm,
there is a fatty deposits build up in the inside the walls of your arteries, and they can cause you to have the arteries become thicker and kind of harder, and that makes the clots can disappear from there, and they can actually start to form clots, and they can move away from that source and cause fatty deposits somewhere else. Small vessel disease is another thing, which is where tiny blood vessel disease within your brain are damaged. That is another
mhm,
cause of stroke. The atrial fibrillation and some other heart conditions,
mhm,
which can also cause blood clots to form in your heart, which again tend to move from the heart into different parts of the brain. And finally, but not the least, is the arterial dissection, which there is a tear in the blood vessel, and that allows the blood to get between the layers of your artery walls, and that can happen for whatever different reasons, but they can go it. So this is the reason why the block happens. But the reason why the block happens, there are other medical conditions that are risk factors for which you have actually put down slide here very well.
Mhm.
You
Mhm.
already know that hypertension is a big killer, or is such a big cause for strokes, and that can cause you to have the other type of strokes which we didn't talk about, which is the rupture of blood vessels, which
Mhm.
actually can cause which is because of hypertension. High cholesterol, again, there is a good and bad cholesterol. The good cholesterol is the HDL cholesterol, which is what we needed. But the LDL cholesterol, which is the bad cholesterol, which when it builds up into the circulation, that can that can produce clots in itself. Diabetes, we know that there are two types of diabetes, diabetes 1 and diabetes 2. Diabetes 1 is about 10% of the population of diabetes, where you have it at young age. There is no insulin production within your body.
Mhm.
Diabetes 2 is when you have insulin production, but that is not enough. Or even if it is enough, there is a resistance to rest of the body to kind of respond to the insulin. So the
Mhm.
type 1 and type 2 diabetes both are quite common in people with diabetes. Atrial fibrillation, we already talked about. And heavy smoking, we know that somebody who smokes more than 100 cigarettes a week are likely to have their stroke risk about 5 to 6 times more than somebody who doesn't smoke at all.
Mhm.
Obesity is something very topical. We know that the whole idea of health is about prevention, not treatment.
Mm. Oh, we lost you. Oh, sorry. I think you have, doctor. I think you have unmuted
Yeah,
yourself. Yeah,
got it, got it.
yeah.
Yeah.
That's it. Yeah.
So obesity is another thing. Obesity is something, in any kind of chronic disease, we like to prevent it rather than treat it, because prevention is better than cure. And there is no real cure for stroke as yet. We are still fighting the causes hard, and so prevention is the
Mhm.
best and the easiest way. But obesity is one such thing, and especially South Asian population, there's central obesity, which is the waistline, which is about
Mhm.
is very important to prevent you to have stroke. Normally, the suggestion is that you should have a BMI of 25 or about, or 25 or above, is called obese among the native
Mhm.
population. But in South Asians, I would call that to be too high. Maybe it should be 23 and above. But the fact is that waistline, where they deposit fat around the waist, is a high
Mhm.
risk to stroke as well. So those are
Yeah.
different things that we didn't talk about. Several other conditions we should have probably talk about sleep apnea, people who find it difficult to sleep. We
Mhm.
also haven't talked about migraine with aura, not just the normal migraine. People who have got aura with the migraine are slightly higher risk of having strokes. We
Mm.
also know of certain other genetic conditions that can also kind of mimic strokes as well. So it is this. There are few other causes relating to stroke as well. So it is a mixture of different intrinsic factors, intrinsic risk factors. When they all combine, and that's when it explodes. That's when you get a stroke.
Wow, amazing. Thank you for that, Dr. Andol. Actually, you mentioned migraine. A very good friend of mine is actually headache nurse specialist. She's there, Susie Mamango Lagrata. She's on her way to become a doctor in migraine. Yeah, migraine. She uses neuromodulation for migraine. She's a specialist in migraine. So maybe she will have some questions later on, or you can ask her.
Yes,
Because
but
we encounter a lot of stroke mimics which are like
indeed.
migraines, isn't it?
Hello, Susie.
Yeah.
Nice to meet you. And I hope that you will tell me more about stroke as well. But as far as I know, it is the migraine with aura that worries me. Just the migraine on its own, it doesn't worry me so much. But
Mhm.
again, if somebody is taking lots of tablets and medications for migraines for years, of course they are at a higher risk of strokes than, let's say,
Mhm.
somebody who doesn't have any migraine at all.
Wow, amazing. So we now know the causes or the predisposing factors of stroke. Now let's go now to the types of stroke, which you already briefly mentioned earlier. Yes, can you please tell us more about the types of stroke?
Right. So we already talked about ischemic stroke, isn't it? So
Mhm.
that is where there is a blockage of blood vessel in to the brain, and we already talked about how the blockage forms because of the causes what we talked about. Now, I think we'll spend some time on the hemorrhagic strokes, which is one
Mhm.
which is, well, it depends on how you see it, but this is the one which can be prevented.
Yeah, yeah.
This is one type of stroke where you can control your blood pressure, and then you can actually stop the blood pressure from being blood arteries to
Mhm.
rupture or cause to rupture. So there are two types of hemorrhagic strokes. One is an intracerebral hemorrhage, which is there is a bleed in within the brain, and then there is another one which is the subarachnoid hemorrhage, which is on the surface of the brain.
Mhm.
Now, there are several causes of hemorrhagic strokes. We talked about blood pressure quite often because that is what we
Mhm.
can prevent it. But there
Mhm.
are a
Mhm.
few other things that you can't prevent it so much,
Yeah. Mhm.
which is a condition called cerebral amyloid angiopathy, where there is a protein in the blood vessel, which is amyloid, which actually makes the blood vessels to kind of go very thin and weak, and then they can
Mm.
rupture at any time. The other cause of hemorrhage is also an aneurysm. There is a weak spot in the artery, where there is a bulge in the artery and the walls have become thin and weak, and that can
Mhm.
sometimes burst. But again, aneurysm is something that we can be repaired, that can be
Mhm.
through different things that we can talk about later. And the reason why somebody has aneurysms is some things that you develop at birth, and a few things is just, and also risk factors such as smoking and blood pressure makes the aneurysm more likely to burst. So
Mhm.
that's something else. Now we already know that we take blood thinning tablets for different reasons. So for warfarin for thin the blood and keep our blood circulation smooth, and somebody who has got heart problems, we also take blood thinning tablets to keep it smooth. So those anticoagulant medication can also cause you to have a bleed in the brain. And very well, I say rarely because the number of people who use illegal drugs are very few, thank God for that. But illegal drugs such as cocaine can also cause a few people to have a stroke as well. Now, in this
Mhm.
mix, we may want to add it's not a hemorrhagic stroke, but there are a few other, there are some certain case reports where COVID 19 is
Wow. Okay.
to be one of those causes where they cause when they cause you to have small little clots in the circulation. So those could be other reasons why you may get it. So this is not a comprehensive list of
Mm.
all the causes, but these are the major causes of somebody to have a stroke as such. So this is so if you were to, I don't know how to say this. So if you were to suddenly give me a target and said to me, Shri, I'll give you 20 days and I want you to reduce the risk of stroke in the population of Romford by 30% in the next
Mhm.
30 days.
Mhm.
I probably would choose to check the blood pressure medication of everybody in Romford, treat their blood
Mhm.
pressure, and that itself will reduce the risk. Of course, whether I'll sustain it or not is a different issue, but
Mhm.
that
Mhm.
itself will reduce the risk of somebody having hemorrhagic stroke in itself very quickly. So it's very important. I'm coming up to 50 as well. So I think there are lots of my good friends. You don't have to touch up to 50, but even before that, it's important to make sure that you check your blood pressure. I've got loads of my friends and in the family, and I know loads of people who have got blood pressure when they're a lot younger, below before 40 as well. So don't wait till something happens and then you actually go back. Make sure that you pay attention to the symptoms what you have of blood pressure, whether it be the vision, the headaches, whatever you have. Make sure that you check your blood pressure. Make sure you are kind of you are aware of the facts, your risk factors. Make sure you check your blood sugar levels and make sure that you eat healthy. And all, again, diet is very important and have good exercise. Those things are very important. You don't need to have a stroke then to go back again. But these are the things you need to do, whether you have a stroke or not, because that will stop you from having any stroke later on in life.
Wow. Thank you for that, Dr. Andol. So there you can see there that there's a rupture in the blood vessel there, which is the hemorrhagic, and the one which caused the ischemic. which is a blockage in the cerebral artery. Now let's go now, Dr. Andol, to the signs and symptoms. What the people need to know about the signs and symptoms of stroke.
No, it's a
Uh,
tough one, isn't it? So you know this, Jeremy, from yourself. It's a very tough one. So the classic symptoms, which is what we tell in public health education or all the campaigning that happens in December
mm,
on the TV ads, you see the FAST campaign where there
yep.
is a drop, there's a drop on one side of the face, when there is an arm weakness, when you hold both your arms up in the air, you can't hold it in straight line because one arm drops because of weakness. There's a speech problem, speech becomes slurred, or you can't utter a word or something like that. So speech problems, then it's a time to call 999, not waste anything and not
Mm,
waste time to try and do something, but call 999. So that would be those will be the symptoms of stroke. But you and me both know they do not capture everything. There are lots of
mhm,
the stroke will depend upon the damage, the part of the brain that controls that function. If that gets damaged, that will you'll have symptoms. There are certain symptoms which may represent stroke, which is got nothing to do with it. Is when the posterior part of the brain, which is the posterior
mhm,
circulation
yeah.
strokes, which are quite typical when you have dizziness, visual problems, which do not come under this screening group. They can sometimes have those symptoms, and they can have a significant stroke at the back of the brain. So those will be other symptoms that could to be looked at. So essentially, anything that is unusual or any symptoms that you do not recognize to be normal, I would say that be aware that this could well be a stroke. That is what I would say to you.
Yes, amazing, Doc. Yeah. So as what you said, like the posterior circulation, this is when they experience like loss of balance, and also as what you said, the FAS is the only one that we're focusing on, but there are other things as well to look to, like if you got a visual problem, it could be a sign of stroke as well. So as you can see there, when the right side of the brain has had a stroke, your symptoms will be on the other side, which we call contralateral. And when your stroke is on the left side, what will be affected will be the right side of your body. So that's what it's important as well. And if there is one thing that we would like the people to take away from this discussion is actually the fast. The fast test, or the what we call the facial weakness, arm weakness, speech, and it's time to call 999 because it is a medical emergency. Dr. Sri, we have encountered a lot of patients that they come to A&E when it's like 3 days after, that they have lost their
Oh,
speech, or we encounter all those things, as in A&E, that we tell them, "Oh, why did you only come now?" Because they think that it will get better, after a period of time. But it's very important that you
more, you are so right, Jeremy. I mean, more than half the people, the stroke population, who have not had adequate treatment because they presented late to the
yes,
hospital.
exactly, yeah, they came late to the
So
hospital.
that only, and it is, and the way people think is different. I'm not saying that they are bad or anything, but it is just the fact that they think is different. They don't want to bother their friends. They don't want to bother their family. They think it's just one of those things. They don't want to really trouble anyone. Those are different things. There are lots of other dynamics that go within it,
Mhm.
and that's why they
Yes,
don't want to go into the hospital. But by the time they seek some help, it's too late. There's not much you can
exactly,
do
yeah,
about it, and then they're
yeah,
done. So
yeah.
still, half the population, more than 60% of the people come to stroke department with stroke symptoms a bit too late for us to act.
Mm-hmm.
Most of the things, as you know, we need the people to come into the hospital within 4.5 hours. The type of stroke
Yes.
that we can involved in or can do something about is when they have the ischemic strokes,
Mm.
and that needs to be tackled within 4.5 hours.
Mm-hmm. Exactly, yeah. So, for all those who are watching right now, this is the very important part of this discussion. If there's anything that you need to take away, this is it. Just remember, act fast. FAST. I'm gonna repeat it again because this is very important. And by knowing this, it's just like knowing your CPR. You can save lives. But this one, if you know this, four letter, you know, 4 letters. You can save, we can save lives. So take note of this one. Fast, fast, act fast. F is facial weakness, like this, drooping. And arm weakness, which is just one side. It could be just arm or leg or both, but only one side. And speech problems as well, if they become slurred. Yeah, remember, this is what we always say, Dr. Sri, isn't it? If they talk like they had a lot of alcohol to drink, that's how slurred it is. Like, oh, like they had too much to drink, too much alcohol. So, and of course, when you notice that one, when you witness that one, that's what Dr. Andole was saying. We only have 4.5 hours. Yeah. So within 4.5 hours, upon witnessing it, you have to take the patient to A&E. You should call the ambulance, or if you're on your own, call the ambulance straight away. Because, you know, stroke is the number one, as what Dr. Andole said, is the number one cause of disability in the world. Number one cause of disability. I've got more friends who had a stroke rather than cancer, you know. The incidence of stroke is really, you know, 1 in every 5 minutes, somebody's having a stroke. So call 999 straight away. It's a medical emergency, because we will come to the treatment that they can have after they have, the CT scan and everything. So yeah, so that's very important. But we have a question here, Dr. Andole, from our headache nurse specialist. Thank you. This is really educational. How can you differentiate a hemiplegic migraine aura from TIA? Because we will come to TIA anyway. We will come to that one next. So how can we differentiate
Yes,
hemiplegic?
indeed. So just to expand on the previous one, you're absolutely right. There are 100,000 strokes in UK every single year. So we still have loads of people who are having strokes, and there is one stroke every 5 minutes, and there are more than 1.2 million stroke survivors in UK itself. And every 2 seconds, someone in the world will have a stroke. So this is not some rare condition we are talking about. This is quite a common condition, and it can affect anyone, you, me, or anyone in the world. So this is something that we need to be aware of. You wouldn't say the same thing about heart attacks, because you would know that that is important. It's the same here, but it doesn't get the clout it needs to. So, Susie, thank you so much for asking me this question. Now, how do we know it's a hemiplegic? TIA by definition. Let me answer your question first, and then I'll kind of expand on it. So, TIA by definition means that the symptoms only last for 24 hours. That is the WHO definition. But I would say the symptoms should only last in and out in an hour, and they disappear. Then it's a TIA. But if the symptoms don't disappear, if it still lasts longer than 1 hour or beyond 24 hours, then it is not a TIA anymore. It is a stroke. And hemiplegic migraines and aura, they tend to last a lot longer than that. So they don't just come and disappear that quickly. They tend to last quite longer. I mean, in fact, days. And I've known patients who have got the symptoms of weaknesses for weeks and months, if not anything like that. So that is quite important. So the second bit is, it becomes very difficult to diagnose when you have hemiplegia, to say something confidently when you say that it is to do with the stroke, or is it to do with the migraine. The only way we can sometimes do it, or what we do normally in the hospital, is now these days we use the technology to identify it, such as, although clinical signs and clinical symptoms are important, because of course, migraine with hemiplegia would normally classically start off with headaches, and then it goes on to the one side. Usually there is a bit of eye or something else involved in it, but MRI scans are very good at these days to pick up those kind of damage. So if there is a damage to the brain, MRI scans, MRI DWI scans will pick up those damage to the brain early, and then we can quickly say to them that this is related to stroke or a migraine as such. So, but having said that, so your question is, I guess what you are trying to say is that, oh well, is it easy? Well, I don't think it is easy. So TIA or a stroke with hemiplegic migraine and aura are sometimes very difficult to diagnose. That's why we ask them to come around, and then that's the reason why we still end up having to do an MRI. Sorry, did you? So do you want to? Did you hear me there? Sorry, I was muted. I think you didn't get. Get to
No, no,
hear
no.
me?
No, I can hear. Okay, yeah, yeah. I think you were okay. You were not
Oh,
muted. No.
yes. So did you get that message about hemiplegic migraine aura and TIA? No.
Susie, you still there?
So did you hear that answer? Did you hear that message, Jeremy?
Yes, yes,
Did
I did. Yeah, 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 yeah,
you
yeah,
heard
yeah.
that?
Yes, 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 yes. You were not muted. It was okay. Yeah, yeah.
All right.
Oh yeah, yeah. She responded. That's it. Thank you, Dr. Andol. That's what she said.
Indeed, yes, indeed.
Yeah, yeah. So yes, and I just would like to add on that one as well that as what Dr. Randall said, it's TIA is a mini stroke. The symptoms should only last for like 1 hour or so, and but according to the World Health Organization's definitions, the symptoms last for 24 hours and it should disappear. But the I think the important message is don't leave it for too long, and because we get a lot of patients who present to A&E when it's quite late and we can't do anything about it anymore. So I think that's just the message. And TIA is actually like a warning sign for a bigger stroke as well. So when somebody has got a TIA or when you have a TIA, don't take it for granted, because that is a sign of there's something more serious will come. It will be a bigger stroke next time. So don't take TIA for granted. I think that's just the one thing that main thing that I would like to add. So Dr. Andol, we're just gonna pause for a quick commercial break. Yeah. So let's just catch our breath.
Just
Okay.
before you say that, I wanted to
Yep.
say 1 in 12 people, that is the 8%, will have full stroke within a week of having a TIA. So it is very
Wow.
important
Okay.
that, so that is why it is like, yes, it is like a chest pain before a heart attack.
I
TIA
see.
is
Yeah.
a stroke.
So I hope you guys paid attention to that one. That after TIA, within certain amount of days, a big stroke
Within a
will
week,
come within a week. Within a week. Yeah. Within a week.
8% of people, that is 1 in 12 people, will have a
Mm-hmm.
stroke within a week after they had
Yes.
the stroke,
Uh,
after the TIA.
so don't take TIA for granted. So we'll be back shortly.
And I'm going to have a coffee.
Yep. 2 minutes. 2 minutes.
All right.
Okay. There you go. So, oop. So how are you guys finding it so far? So I hope you're all learning something from today's interview with Dr. Sreeman Andole, lead consultant for stroke, and he also approved stroke guidelines in the with NICE, which is a National Institute for Health and Care Excellence. So that's very important. So let me just share this slide again. Oop, share screen. That is very important, that one. So act fast. So I'm flashing it again because as what I've said earlier, it's like having your knowledge or skills in CPR that you can save lives. But this one, if you know fast, you act fast, you can save life by preventing somebody from having, the devastating effect of stroke. Because we have 4.5 hours only, that window wherein we can give this treatment, which Dr. Sri will discuss late. We will come to that one, to the diagnosis and treatment of stroke. But please learn this one. Fast, act fast. Facial weakness, which is like this, drooping on one side. But there's a condition as well, which is a neurological condition, which can, we have stroke mimics in short, that could show up like a stroke, but it's actually something else. But still, come to A&E or emergency department to get checked. Yeah, that's the most important thing. Don't hesitate, just come to A&E. So facial weakness, you have arm weakness when one of the arms actually droop, or they are weak. You ask them to bring their arms up, and if, or of course, if it drops, then that's it, a drift, pronator drift. And speech problems. If you can remember when you're drunk and you had a lot of alcohol, the way you talk, that's slurring of speech that we're talking about. There are other causes of obviously slurred speech. Somebody could have Parkinson's disease or any other neurological problem that has impairment of speech. But it is very important to get checked. And sometimes infection, if somebody has got a Parkinson's, they are speaking clearly, but then they had some sort of infection, like a urinary infection or chest infection. It can worsen the symptoms of certain disease, and you might think it's a stroke. But as what I've said, always go to A&E to have it checked and have it, so the doctors will find out in A&E if it's real stroke or not. But main thing is always get checked. And T is also time to call 999. Yeah, it's a medical emergency. So we're back, Dr. Sri.
Please, yes, indeed.
Yes.
I'm just having a coffee. There is no link between coffee and stroke. That much I can tell you.
It's okay. Let's just show them what it looks like on a CT scan, because we will come to the diagnosis and treatment.
Wonderful.
So let's talk about the diagnosis and treatment. So we tackled about the predisposing factors, what causes it, the incidence, the signs and symptoms, and we also talk about TIA, and how can we, obviously the FAST as well, the FAST test, and we come now to the diagnosis and treatment. So how can we diagnose a stroke?
Right.
Dr.
Okay.
Andole.
Right. So the first thing I was going to say to you was that diagnosis is essentially clinical.
Yeah, clinical diagnosis. Yeah.
So clinically is very important. You need to know the symptoms of stroke are usually sudden onset.
Yeah, sudden. Yeah.
Sudden onset of weakness, or whatever the symptoms of stroke, what we just said, on one part of the body, which we call as a focal neurological deficit. So those are the critical signs with upper motor neuron signs. These are all the clinical exams, but essentially a clinical diagnosis is the key one. But in the recent past, we have got there are lots of medical technology has evolved, and we have got lots of different things that we can look at, use it to diagnose the stroke. The first and the most important bit that we use for every patient with stroke, and in fact it's one of the target, is that as soon as the patient comes into the hospital, within 1 hour, we need to have a CT scan done to them.
Scan.
So within 1 hour, that is. So this is even in patients who we don't intend to treat them immediately, even though they don't come within the 4.5 hours window, we still need to get them done a CT scan within 1 hour. So the CT scan is the key one. Increasingly, we are using MRI scan as a initial modality of investigation. Not possible everywhere because of lack of resource and the specialist tools, the radiological investigation that are necessary. But MRI is another more definitive way to tell what type of stroke it is. So CT scan and MRI are the two critical ones to diagnose the stroke. So I think, Jeremy, you could explain it better than I would. So you got a CT scan image here. One is a white blob, another is a dark shadow. You can tell them, and you've written down saying it's ischemic and hemorrhagic.
Yeah.
But you can say what you need to, yes, and then I can expand on it.
Yeah, so basically the ischemic stroke. So the CT scan should be done within 1 hour. The patient presents to A&E. The reason for having a CT scan is first to differentiate if it's a bleeding or it's ischemic. Because if there's a bleeding, which is on the right side, this one, the right side of the screen here, it says hemorrhagic. That white thing there is actually blood. Yeah. So we have to differentiate if it's a hemorrhagic or ischemic, because if it's a hemorrhagic, that will change totally the type of treatment, because you won't get this what we call thrombolysis treatment that we give to patients. But if you have this like hemorrhagic, ischemic one, this is when if everything is if all the boxes are ticked, and then you can have the treatment what we call a thrombolysis, or even thrombectomy. So that shadow there, that darkened part there, is the stroke. This is a huge stroke in the middle and the anterior territory, Dr. Andol, isn't it? So yeah. And the thing with CT scan is if it's an acute one, it doesn't always show in the CT scan. Yeah.
Right.
So yeah,
Correct. A CT scan is only to rule out,
the
essentially, when you
bleeding.
do
Yeah,
it very early, to rule out a hemorrhage, and that is what.
exactly. Yeah.
Yeah.
Yeah. So that's it. So if there's no bleeding, and if it's ischemic, then we will think about thrombolysis, which is the emergency treatment for stroke. And back to you, Dr. Andol, or anything
Indeed.
you want to add more? Yeah.
Well, what I wanted to do is move away from what we're going to do when you get to the stroke unit, but I just want to focus on the fact that how important is it to come into hospital. Can I
Yes.
just
Yes.
focus on a couple of things, first of
Yeah.
all?
Sure. Sure.
So
Yes, please.
anyone who's got a stroke or who's been diagnosed or who people are thinking of that they have symptoms of stroke are transferred to a specialist hospital unit,
Mhm.
which is called a stroke unit, which is, and especially if it's acute stroke, they go into a hyperacute stroke unit where a team of professionals who specialize in stroke care for the patient. We know there is a good amount of data available there that patients who have been cared and treated in a stroke unit are more likely to be living independently by themselves 1 year after they had the stroke.
Mhm.
Never mind the treatment, never mind anything else. Just by coming into hospital, treated by the professionals and looked after by them, they got more of a chance to become independent than going somewhere else in the world. So that's, I think, those are the critical ones to tell it.
Mhm. Mhm. Mhm.
So it is also, and things are improving all the time. So stroke care is way lot better than even 2016, 17, 2019, 20 is a lot better than what we have at what we had in the past. Um, at the moment, only how to say only not many patients are all that you may think it is okay. Living in London, you may think all the patients are getting this stroke unit treatment, but we know that more than 25% of stroke patients within in the country do not get the stroke unit treatment. That itself is a challenge. So we need to get the people into coming into hospitals, go to the specialist unit to give them the best chance of survival. And then of course the next step is once you come into the right place, then you have the right care, and then you have the right treatment, which is about getting a proper scans done. Then we can think about clot busting treatments, which we're going to talk about a bit later on, the thrombolysis and the thrombectomies.
Yes. Uh, Thank you for that, Dr. Andol. And yes, I think we can go straight to the treatment of stroke after we know that the scan is clear. Say, for instance, there's no bleeding, and then we decided to thrombolyze the patient. So, tell us more, please, doctor, about this thrombolysis and thrombectomy,
Right.
which is an
So
emergency treatment for stroke.
indeed, this is an emergency treatment. We already did say, for the sake of kind of clarity and not to provide any ambiguity, that the
Mm.
treatment is only the treatment acute treatment can only happen if you come into the hospital 4.5 hours before,
Yep.
not later after your
Yep.
stroke symptoms have started.
Mhm.
So thrombolysis is a treatment that uses drugs to break down and disperse the clot for the people who have had ischemic stroke. Not all types of stroke, the ischemic stroke, where you have actually got a clot in the blood vessel. And it is, and like I said to you, it is only up to 4.5 hours after the treatment. Now, the clot busting drugs increase the chance of good outcome by about 30%.
Mhm.
So 12% of stroke cases in England, Wales, and Northern Ireland are eligible to receive thrombolysis, which is equivalent to about 10,000 people. And 85% received thrombolysis in 2016-17. So a lot of people are eligible to receive treatment, and these people will get those treatments. So that will be increasing their chances of survival. 6 out of 10 patients in England and Wales and Northern Ireland um, have arrived. We've already talked about this. 60% of the people have arrived into hospitals after the 4.5 hours
Mm.
in the past. So there's not much we could have done with them. So they've already gone. They've lost their they lost their golden hour, as it was. So the average door to needle time is now slipping. Yeah, when they go slip out, the longer you take for the treatment to happen, the more likely that you're allowing the brain cells to damage. You know that there are
Mhm.
4 billion brain cells get
Mhm.
damaged every second. So that is the rate at which the brain gets destroyed. And the latest in the treatment is what we call as a mechanical clot retrieval, which is a thrombectomy. So this is a thrombectomy is a procedure used to mechanically. So instead of delivering a drug through the vein and expecting the clot to burst, a thrombectomy we would put a pipe in through the groin usually, and you go up to the clot and you physically pull the clot out. Not unfortunately, not many centers in the country can do it, and there are more increasing number. 10% of the people who end up going to stroke unit are eligible for thrombolysis. So I said to you that there are about roughly 10 to 13,000 stroke patients coming to London every year. So 10% of them, so roughly about 1,000 odd people, are eligible for thrombectomy in a year. So we had only done about 200, 300. So we are not even halfway
Mm.
to the section. So it's going up all the time because only few places do it, and even those places who do it at set given times. But the facilities are improving, and as time goes by, I think there are lots happening elsewhere. They're planning to set up new centers. They're trying to train other people with other specialties to be able to fill the gaps in the workforce, to be able to deliver this kind of special treatment to the patient. So that the clot retrieval, so the clot busting treatment such as thrombolysis increases the chance of good outcome by 30%. Clot retrieval increases the chances of good outcome by more than 50%.
Wow.
So
Amazing.
there is a significant. So if you're asking me,
Mm.
uh, how to say this? If you're asking me, is thrombectomy better than thrombolysis? Well, it is. You can't just put a random question, but the fact is,
Mm.
thrombectomy gives a better outcome.
Yeah.
But
Yeah.
unfortunately, not all strokes, not all the clots are amenable for this kind of treatment. Not everybody is eligible for that. It
Yeah.
depends on the location of the clot and other stuff. I hope
Yes,
that's
that's true.
clear. Yes.
Amazing. And I've seen how effective thrombectomy is because I have patients like, they couldn't really move their arm or they couldn't talk. And then after thrombectomy, straight away, the patient will call you, look, I can lift it up now. I can lift it up. And you just feel, you feel that you've done something really good for the patient. You save the patient's life because If not, that could be a permanent disability. So that's another thing to remember. If the patient didn't have that treatment, that is a permanent disability. So yeah. So yes, thank you for that, Dr. Sri. So of course, after the treatment and everything, the patient is ready for discharge. But before that, of course, we have some rehabilitations to do. So they need to
Indeed.
recover. Most patients will go home with aspirin and clopidogrel. With all this treatment, but rehabilitation is actually very important as well, especially if they got deficit.
Or you hit the nail on the coffin. I tell you what, if there is one thing, I know it's everybody is focusing on the front end of the stroke pathway because it is sexy, it's great, it gives you great results and all that, but actually it's very important to focus on the back end of the pathway too, because rehabilitation is very, very important. More than 1 million stroke survivors in England need post-acute care.
Yes.
So this is not about just kind of one here, one there. So there are lots of people who need post-acute care. And although the biggest steps in recovery are usually in the first few weeks after stroke, the brain has the ability to rewire itself, which is known as neuroplasticity. Means it's possible to continue to improve for months to years after they have the stroke. So it is very important that they have that. And now you know that most of the therapy beyond a couple of weeks into the hospital is carried out by teams such as early support discharge teams or community rehabilitation teams that they do it. And only approximately, unfortunately, only half the stroke survivors in England uh, discharged have got have been assessed by appropriate specialist therapy specialists in the community. So I think it's still a challenge. Even there, we have got a workforce issue, but there is still long way to go in rehabilitation side of things as well. And life after stroke is a quite complicated thing. So I don't want to bore you with lots and lots of statistics, but 3 out of 10 strokes will need a 6 months review following their strokes. 1 in 5 stroke survivors ask for psychological support, and also 15% of post-acute services in England um, or people return to work after they have their strokes. Only 15%. Most of the people don't even return back to work. So there's a huge gap in vocational rehabilitation itself. And 1 in 3 areas do not provide support for the carers and the families of stroke survivors. You know that is it's a huge burden, not just to the stroke person. It's about the whole family. The carer takes on a lot of things. And from commissioning point of view, 1 in 5 commissioning areas in England do not offer access to speech and language therapy for stroke survivors. So there's a lot to be done.
Yeah, at the back end. Yeah.
Correct. There's lots
At
of
the back
gaps
end. Yeah.
there.
Mhm.
There are lots of gaps there. There's a vision set by the Stroke Association as well. There is a vision set by the stroke body, but it is there's a lot to be done and a lot to be achieved in stroke. But we'll go back, and the reason why we are all sitting here and talking about it is that we want to bring it to everybody, saying that we wanted, if not, if we don't spread the message, at least we spread the message within our families, whoever is
Yes.
watching. That is enough. I think if 10 families are, or 5 families talking to 10 of them individually, we've actually educated about stroke to about 100 odd people today. It's enough. It is worth our job. I think if we tell them how important stroke is, if they need to seek medical advice soon, without delay, call the 999. Those are the key bits. If we drill that message, I think our job is done. We're happy. We should be
Yes.
able to sleep peacefully.
Amazing. Yeah. And prevention is always important than cure. Health promotion and health prevention rather than curative and rehabilitation. Because if we focus on the prevention and the health promotion part of the what you call this one, we will not be needing to go to the curative and the rehabilitative side of the health spectrum. Health and
So,
illness spectrum. Yeah.
so the cost of stroke to the UK society is £26 billion.
£26 billion. Wow.
26
That.
billion pounds. And all the
Mhm.
new cases of stroke, they cause you another 5.3 billion a year. So
Wow.
it is not just it is not, health is wealth, of course, but it is expensive as well. It is not that
Mm, mm.
as a health economy, we won't survive. I mean, so this is the best way to prevent stroke, is the best way to save money for the country.
Yes, yes. And not only that, as well, the burden that we will leave to our family as well. People has to, when they get discharged to the hospital, you need family support as well. And if you have, if your most of your family members are actually working, they have their own family and kids, that will be compromised as well. They have to take their annual leave, take the days off in order
Absolutely,
to. So it costs a lot of things, and not just money, but time and effort for everyone. And so really prevention is the best thing to do, instead of going to that one. So is there a, chance of, you had a stroke, we talk about secondary prevention, we put them on medication to prevent the recurrence, but can you talk us through about the chances of having a re-stroke again once you have a stroke?
yeah. Sorry, apologize. There is like any other chronic condition, recurrence of stroke is equally possible, and there is a 1 in 10% chance of stroke coming back in an year. It will
Mm-hmm.
depend upon the risk factors, how well you maintain the risk, and how well you control those risk factors. If you got diabetes, blood pressure, obesity, exercise, good food, these will all kind of play part into those recurrence.
Mm-hmm.
Unfortunately, there are certain things that you can't move. That we already said about ethnic influence on stroke itself. Social deprivation is another one, and those things you may not be able to move too much, but there's a lot that can be done as far as risk factors is concerned. Um, the key bits about recurrence is that the greatest risk of having another stroke is in the first 30 days
First 30
following.
days. Okay. Yeah.
And also they say that 1 in 4 stroke survivors will experience another stroke within 5 years.
Okay.
That is the statistics, but I think we are much better at treating patients. You and me both know, if we worked in the same unit for more than 10 years, and if we were to just keep treating patients as they come back again, we would be out of business. So
Yeah.
no, I don't think we do much better than that. But the
Mm-hmm.
statistics are 1 in 4 stroke survivors will come back with another stroke within 5 years.
Mm-hmm.
Over a quarter of who have had a stroke have had a previous TIA in the
Mm.
past.
Yeah.
And
Wow.
also 6% of stroke patients have have had stroke while they are still in the hospital.
Yeah. Yeah.
So they are recovering from the hospital, but they have the stroke while they are there. That is 6% of them. And TIA are, as we know, we've already talked about the fact that TIA are being increasingly diagnosed now. So we know that TIA is a great risk of somebody having a stroke if you don't deal with the TIA, because there is a 17% risk of them having a stroke within a year.
Exactly. Thank you very much for that, Dr. Andol. And of course, after they get discharged, and of course, they can always go to Stroke Association. They get a website for more information, for their community support, um, like Stroke Association. What other agencies are there, Dr. Andol, that can help with recovery from stroke? And of course, while they are in the community after having
You
a
know,
stroke, that they can call.
correct. I will say, if you go to the GP, there will be usually Stroke Association has got self-help groups available. Then there are some charities that will come around. UK is another good charity
Mm-hmm.
that helps
HUK, yeah.
people. Yes, AF, that helps people with stroke when they're old. There are some social organizations that will help you as well, depending upon which part of the country you live in. So there is help available. Not enough, sadly, but there is
Mhm.
some help available, and they do a lot of good work. They put in a lot of money into stroke research and stroke cause, and they have. I mean, so it's, and if somebody is really interested in joining up any of those charity works, they can follow them up on their website, stroke.org.uk. You can join in their charities, including the London Marathon. That would be one great thing. If anyone wants to take up something, that would be brilliant to take up, and run for Stroke UK as a London Marathon runner, and that would be one good way of spreading the cause, as it was.
Wow. Dr. Andol, thank you very much for your time, for sharing us your expertise. And I've got you my virtual glass of champagne for you. Thank you very much.
I like this. I like this.
Thank you very much. Thank you very much, Dr. Andol, for
You
your
can,
sharing your expertise. It's been a pleasure working with you and when I was in Queen's Hospital. And thank you for your support with me as well personally, with Germination, with all my activities online. And all I can say is, all the best and thank you very much. And that's a glass of champagne for you.
well, thank you so much. Jeremy, by the way, please continue your good work. And I tell you what, I think it is important that you need to know that a lot of people take inspiration from what you do as well. So I think please do. And thank you so much for inviting me. And I hope that, like I said to you, I like to see that in a year's time, this is not watched by 30 odd people, but 300 of them. So I
Yes,
will
that's the
see.
main aim. Yeah. Save
Indeed,
lives
yeah,
to this
indeed,
message. Yeah. Yeah. Yeah.
absolutely. Thank
Yeah.
you so much.
Thank you very much, Dr. Andol. Thank you for your
Thank you.
time.
Bye-bye. Bye.
Thank you. Bye. Bye. There you go. So let's just give a shout out to all those people who are with us. We have Cherry Kucheros. Good afternoon, all. Hello there. And Cherry, myself, and Eleanor from Wales. Hello there. Hello from all the people from Wales. We also have Christopher, Josh, Noel, Kalise. Good afternoon, Jeremy and Dr. Andol. Hello there, Christopher. How is work? Are you back to work now? Great, 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 great. And Cherry, that's very true, Dr. Andol. And sorry to hear about that one. Yep. And Mark Barton, hello there. Hello, Mark. Thank you. And we have Maita Martin of DJ News at Ladbroke Grove. It's a convenience store. Hello to you, Maita. And of course, we have our headache nurse specialist, more than a specialist actually, Susie Mamangon Lagrata. Thank you for that question. And yes, we do get a lot of stroke mimics, which are actually migraine. They have the same symptoms actually. They have the facial droop, they have the weakness, they have the slurred speech. But yes, that's why it's very important to get checked as well. Because it could be a stroke. It could just be a stroke, a hemiplegic migraine as well. But it's very important to get checked. And that's that's what Dr. Andel said. Most of all, the most important thing is bring yourself to the hospital when you get all the symptoms to be checked. And then yes, and then we have Cherry. Yes, you heard it. We have Netno Dones Rivera. Thank you there. Not yet, still at home, but very soon. Yes, yes. Stay safe. Stay safe. Yes, Christopher. Yes. Thank you for all your support, and I wish you all the best. And soon, yes, you'll be back to work. And for all those who I haven't mentioned, we have Juliet Olinoco Di Mayakyak, Cathy Valdez, our pop star and supermodel, Julie Simmons, hello, Ate Julie. Abigail Sarte, hello, Kumare. And the president of Filipino Nurses Association UK, Ariel Llanada. Graham Fox is watching. Eileen Kagurangan, hello, Ate Irene Kagurangan. Joshua Ateyobi, my colleague from General ITU Queen's Hospital. Janet Gloria Dispo, hello. And Carl Dimen, hello, Carl Dimen. How are you? Florentina Paloma Bunker, George Orta, The second, hello, my classmate since elementary and high school. He's actually the, I think, undersecretary or more than that of justice in the Philippines. Yes, yes, he's in the government with a high position, undersecretary of justice. If I'm updated, please update me, George. I'll get in touch with you again. Thank you, George from the Philippines. Sharina Cruz Caras, thank you. Mary Monteverde, my colleague, the Discharge Hub. Nicola Restal, and Chatty Dionisio, Molly Walker, Emily Magdael. Hello there, Emily. Thank you for watching. Samantha Magiri. Hello, my colleague from Cardiothoracic ICU in the Heart Hospital. Ellie Hawkins. Yes, see, our stroke administrator, ward clerk in the Queen's Hospital stroke unit, hyperacute stroke unit. Sister Maria Curtin. Hello. Our sister, ward sister in neurosurgery, Riza Bongais, Hermel Elagan, hello, Chairman Hermel, and one of our stroke consultants as well, Dr. Sorin Longana. Yes, you can watch this back. Thank you, Dr. Sorin, for watching. And yes, that's all. So just some special announcement that I would like to share to everyone. Ooh. Special announcement, special announcement. There you go. Let me just remove that one. Yes, the Filipino Nurses Association UK, FNA UK will be having the grand launching on November 14, 2020 from 1 to 7 p.m. Please save the date and please visit the Facebook page, which is Filipino Nurses Association UK, and the website is www.fnauk.org.uk, and we are on Twitter as well at Filipino Nurse UK, and of course, I am a proud member. There you go, Filipino Nurses Association in the United Kingdom. So calling all Filipino nurses, just to let you know, there is an association which will be looking after you, your welfare, your, as a professional. We're here, the Filipino Nurses Association. Please visit our website, and we are here to help. So I'm a proud member of that one. So watch out for our grand launching. Rosel Urbano, hello there. And of course, I would like to, oops, sorry. Sorry. Sorry about that. Can't help it. Yes, and my project. The next project will be this one. JhermiNATION Got Champion Talent Competition starting on November 7, 2020. The grand finals will be January 2, 2021. This is open to all nationalities, all around the world, open to all ages, open to all talents. Sing, dance, you act, stand-up comedian, a pet who can talk, your grandma can still break dance, everything. So everything is, you can, all you need to do is to send a 1-minute video of your talent to Jermy_Roy at yahoo.com. And that's JHERMY_ROY at yahoo.com. So that's our announcement. That's my announcement. And Rosel Urbano, hello there. Thank you for watching. And so, what is your takeaway? What is your takeaway? What is your takeaway? I always make sure that the time you spend here in JhermiNATION, you will get something out of it. Your time is very important. Actually, time is more important than money. But the most important thing that I just would like to add again, and to make sure that we drill this into your minds. That is the word. Yes, drill it into your minds. If there is anything that is very important to take away, is this one: fast. Act fast. Facial weakness, arm weakness, it drifts. Speech, when you're drunk, how a drunk person speaks. That's the slurredness of speech. And if you see any of these symptoms, you witness it yourself right in front of you, or if you, God forbid, if you are having these symptoms, please call for help straight away. This is a medical emergency. There is one in every 5 minutes, one is having a stroke. And every 2 seconds in the world, one is having a stroke. In my circle of friends, I can count, there's already like 10 who already had a stroke. 10. And for more than like cancer or any other, this is the most common cause of disability in the world, because within that 4 hour and a half window, if you lose that window period of having that treatment, the emergency treatment for stroke, which is thrombolysis and thrombectomy, if needed, if that is appropriate for you, after the doctor has evaluated you, after the stroke specialist has evaluated you, it will save your life, and it will help prevent a permanent disability. So if there's anything, remember this one: act fast. Witness facial weakness, arm weakness, speech problem, letter T, time to call 999 or emergency. Call the ambulance straight away. So that's all I've got to share to all of you. And I hope I haven't forgotten anybody. And see you again. So thank you very much for watching JhermiNATION, our hub for health, arts, and business. And this is Jeremy, your host here in London. Bye for now. Thank you very much. Namaste.